Hey, Carey, welcome to part two of our episode. Thank you so much for coming on the podcast. I know a lot of people will be very excited to hear what you have to say. And I'll ask you the same questions that we ask to all our podcast guests. And question one is, looking back, what are you most proud of?
Oh. I think the people gee, if I have any kind of talent, it's recruiting, finding talent and recruiting talent. And if you know Harborview, you know that it's just full of very talented physicians and nurses and interpreters and administrators that I had a role in identifying and recruiting to Harborview. And it's those people that, I don't, after a lifetime, you look back and you realize abstractions are kind of unsatisfying. Real relationships are the most satisfying things. And so it's mentoring people and patients that you took care of and doctors that you trained and nurses that you trained that are the most rewarding. And sometimes those turn into services, or they turn into websites, or they turn into things, but it's not so important, I think, as actually time invested in people.
I cannot disagree with that, but I would like to nudge you into talking about potentially a couple of concrete examples of the people that you identified and hired and trained that turned into services and programs that continue serving Harborview patients to this day. And I think you'll know what I'm talking about.
Right, there are several, and I think the one that people always see as the most useful is probably community house calls. And I think that community house calls had its development, in my mind, in two different ways. One is that my ex-wife, was involved in migrant health stream in the Midwest. And so migrants would often come from Florida or from Texas and kind of come up to Michigan and pick and go back. And so identifying promotoras and people to work with migrants was something that she was engaged in. I watched some of the promotoras follow people from Texas back up to Michigan and then back to Texas. And so I was intrigued by that. But this came after a period of time that she and I worked in Nepal, where I did my graduate work in anthropology. And I was always interested in traditional healing. And that partly came out of my Pentecostal roots. I was raised as a Pentecostal. I'm not Pentecostal anymore, but I was raised in a Pentecostal church and with ecstatic healing and ecstatic traditions. And so I was always intrigued by those. And so when I was doing my graduate work in Nepal, I worked with traditional healers that were involved in ecstatic traditions, right? These ancient shamanistic traditions. And I was fascinated by how they cared for patients who had constellations of illness that they identified and treated and talked about. And yet they didn't correspond or correlate to anything, of course, biomedical. I would have at that point been in the middle of my medical school training because I did both anthropology and medicine at the same time. And so I would probably been a third year medical student in Nepal. And so there we worked with informants, right? Quote, the traditional term was key informants. And these were people from the community that understood not just the formal language, right? We were told to learn Nepali and hit the hills. We learned some Nepali, we went into the mountains and we worked with the Tamang, who didn't speak a word of Nepali. They spoke a little, and so it would be like going into Oaxaca and working with local people and realizing Spanish is a second language. Mm-hmm. And so now you realize we're dealing with a different tradition completely. And so I think the key informant was critical because he understood not only local language usage, but he also understood kind of the power structures, and he understood just the larger context and could unpack that for you while people were explaining to you something specific. He knew that you didn't understand the larger context that they completely were assuming you understood as they explained something to you, right? And so, like, there's such a deity that happens on this and this day and this part of the mountain, and if you're there and this happens, and they didn't explain any of that. They would just talk about what had happened as though it had significance, and I'd realize, I don't know what the hell they're talking about. And then the key informant would explain all the context, and I'd go, oh, now it makes sense, right? We all get that. And so that was so that came out of anthropology. So that when I came to medicine and began to work in medicine, and I came to the clinical scholars program at the University of Washington specifically to study anthropology, to extend my anthropology training, because that's what I wanted to do. And so when I came, I began to work with the Cambodian community and began to work in the clinic that I eventually took over and stayed in for the next 32 years. And so there I began to see the larger issues around language access. So that's not how I came into it. I came into it with a very different lens. And then I began to realize, okay, you know, now I'm seeing 8 patients in the morning, and each one speaks a different language. And so all of the challenges around linguistic access were very different from people from Central America to Eastern Europe, and now Somali, and now you know, Cambodia. And so we were flipping back and forth constantly and adjusting our register, our body language, and everything. And so I think it was realizing that those dynamics that really led us to look at developing what we called at the time case managers, cultural mediators. And the idea was simply that initially that they would be able to work with providers and explain context. And when it became relevant, not always, you don't explain everything, but those contextual things that are really important, and be empowered to do that. And then also follow the patients at that time came out of Southeast Asia that we were seeing in large numbers. They were very unfamiliar with Western medicine. That's changed over time, obviously, but at that time, they were very unfamiliar with Western medicine, and all of the dynamics and the order of the workup and all of those things were lost on them. And it really helped them to have somebody that explained that you can't go see your oncologist until you get that CT scan. If you show up at the oncologist without the CT scan, you're wasting their time, you're wasting your time, and you didn't go to the CT scanner appointment, so you're wasting the radiologist's time. So having somebody that could navigate people according to medical culture, right? And I think that was the other thing that was so important in the development of community house calls was this idea that the most powerful culture in the room is medical culture. And it's bizarre. It has nothing to do with science. It has everything to do with business and finance and administrative culture and speciation of doctors. And so that's what you're dealing with here. And so understanding that and how that works and why you go to urology and not nephrology and that sort of thing, the interpreters under the CCMs, the case managers, cultural mediators, understood that. And not to mention that there weren't terms that anybody understood. You said orthopedics, nobody knew what that was, even if you had the formal term in Russian or in, right? But you said the people on the 4th floor where you went last time, you know, oh yeah, those people. So, or maybe it's Yulia's office. Oh yeah. So it's identified by a concrete thing that means something to those people, not a formal term, right? And so when you've got people that know the hospital, they know who works where, they know the institution, that is local knowledge. And so the CCMs have local knowledge. They know. I would go to them and go, where's eye clinic these days? Because it used to be on 1st. No, it's on 4th, right? They know the hospital and they know all of its shifts. You don't want to go to that guy. He's really difficult, to put it nicely. And so use this other person in eye clinic and you go, okay, good to know, right? Because they know the institution. That has nothing to do with language necessarily. It has nothing to do, it's not only just medical culture, right? It's local culture. And so when you've got interpreters that know that stuff, they are powerful. Those CCMs now, 30, some of them like EOD, 30 years later, 28 years later or whatever, what they know about the institution is, and the history of the institution is unbelievable. It's kind of unmatched by anybody else because they're all over it all the time. I don't know if I answered your question, but that's that program, community house calls, I think, and the navigation. We then were able to speciate it and have somebody like Nuvis, who is a Spanish interpreter that works primarily with cancer patients, right? So that's her bailiwick. Before her was Jose, worked primarily with cancer patients. Others who work primarily with psychiatry. Over time, you know, there were people that had JT that works primarily in surgery, you know, so that they have their area of specialization. It's been beautiful to see that happen. But you also need that generalist that kind of moves across the clinics and understands. And that's what house calls did, I think. And it played a role from prevention in the community where they met. That's where their credibility came from, was in the community, working with people in the community, all the way to the intensive care unit where they would help with end of life discussions. So that when you're in the intensive care unit, the people there would say, you've got credibility because I saw you at my quinceañera, or I saw you at this wedding, or I saw you out in our community. We know you know our community. And then on the other hand, when you were doing prevention out in the community, they would say, oh, you interpreted for my grandma when she was dying in the unit. I remember you. I trust you. Trust your. So that each complementary end of that pole fed the other in terms of the credibility of that navigator. And they're now calling them navigators across the continuum of care. And that program provides that. It's been really remarkable to see it evolve.
Thank you. I think the work that our CCMs do is so meaningful and the program is so unique. I know that, whenever they talk about their work, whenever I talk about their work, a lot of the times I hear, oh my goodness, I wish we had a program like this. Here, I've heard English speakers say, oh my goodness, I wish I had someone like that, even though I'm a fluent English speaker.
Right. No, I think it's true. And that has to do with medical culture, right? It's not the language issue. It's about, well, why are they doing this? How many people's families going? I don't understand. And some doctor will step in and go, well, this is why they did that. And because the logic of it makes sense to the medical practitioner, but it doesn't to the layperson. I think the other thing that I alluded to earlier, which I'll bring up again, is this was all about power. When we designed this, it was about power. And the idea was that for the patient to sort of even the playing field, you needed to have somebody that understood how the institution worked and how medical culture worked so that they could advocate for that person outside of just strict interpretation and say, okay, these are the bigger issues here. And that you validated a person's culture. And you said, this culture is important and we need to understand it. And that came up in so many ways, from female genital cutting to any number of ways where you were trying to understand a procedure, understand the context, and say, okay, we want to be able to speak to this, but we have to speak to it in an informed way.
Absolutely. I think a lot of the time people assume that we all share the same context, the same cultural and knowledge framework. And so that's where a lot of imbalance of power and a lot of misunderstanding comes from, right? So when I'm coming from a Russian speaking culture, and so a lot of people are deathly afraid of cold and drafts and cold water and ice. And so when I talk about these things, I assume that these are things that are dangerous to me, right? And when you talk about referrals and I don't know, choose which pharmacy you'd like to pick up your prescription from, you assume these things are very familiar to me. So that's what I kind of wish a lot of people would do, is take a step back and say, okay, I'm asking you these questions because I'm asking them to everyone. I'm asking you whether or not you take drugs. Is not because I look at you and something in the way you look makes me ask that question. It is a standard new patient intake questionnaire. I ask this to everyone. I don't mean any disrespect or offense. So kind of always taking a step back. And we have people like CCMs who are able to do that and say, okay, let's take a step back. This is what's going on in this appointment. This is what's going on with this patient's understanding of the appointment, or this is what's going on with their life.
So I would say so much of it has to do with trust, right? It all comes down to trust. So if you look at the current Ukrainian situation and people who are older people from Ukraine, those people that were sort of familiar with public hospitals versus private clinics, that sort of Soviet system that they grew up with that was so prevalent in Ukraine at the time, affects kind of what they trust in healthcare, what they don't trust in healthcare, who's the source of this medication, who's the source of this information, because they look for analogs in that old system of private versus public, which don't really play in the United States, but they suspect that they do. And so it affects whether or not people trust what information they're getting from what source. And when you understand that larger context, you can then speak to it.
Absolutely. And, I can speak to some of it myself, even though I consider myself pretty fluent in the biomedical culture, the Western kind of medicine. But whenever I get sent to PT, I do think in the back of my mind, why do I have to do the work? You're the doctor, give me a bill, cure me. Why do I have to go and pay, a copay to work on curing myself? That's not how it should work. So it's somewhere in the back of my mind still, but yeah. Okay, well, so we talked about community house calls. I would like to talk about EthnoMed a little bit as another program in which you played a role and which still lives on and helps countless numbers of patients and providers.
So EthnoMed came out of community house calls in a sense, in that we expected the CTCMs to go get different jobs, and some of them never did. And so the idea was simply that we would learn all of these lessons, of various sorts, and we didn't want to lose them. And so this was when EthnoMed was begun in 1995. And so it was happening at a time that the internet was young. And that was kind of the dot-com boom, you know? And so it was very young. And so we got in there early, and we thought what we'll do is we'll record all of our lessons learned here. And the idea was that it would be a family album. In other words, you don't have pictures of everybody in your neighborhood in your family album. You've got your family in there, right? And so the idea was that the communities that were seen in large numbers at Harborview, the people that whose communities we had real relationships with, and we had relationships with. We went to funerals, we went to holiday celebrations, we went to, you know, it wasn't medically oriented, it was oriented around community life. The Mien, the Hmong at that time, Vietnamese, Cambodian, whoever it was, Somalis, we would be out there in the community with them. And so when that built trust, and so then when we learned lessons, we wanted to record those someplace. So we thought, well, the internet would be a good place to do that, and we'll organize it by our cultural linguistic lessons by ethnic group. But we didn't try to do them if we didn't have a relationship with them. So there's no Japanese. If we lived in LA and we had lots of Japanese community, you know, recent arrivals from Japan, we might do that, or Korea or something, but not happening at Harborview. Our communities were the ones that you see there in EthnoMed. And so it was those communities with which we had a living relationship that we wanted to record the lessons learned. And that's how it started. And then the other thing was the audience. The audience was not patients, right? This is an English-based thing, you know. This is not for patients. There might be some materials there that a doc or somebody might give to a patient, but that wasn't the thrust of it. Because that's really kind of on the people that do that work. If you're an oncologist, it's kind of on you to develop the materials in your language for your patients in oncology, not our job. But what we did want to do is collect that cultural information that we felt was relevant to patient care and create a repository for it. And that's what EthnoMed was. And so the audience was pharmacists, nurses, medical students, and docs who had time to go someplace where they needed to learn a little bit about diabetes management during Ramadan, and they needed to learn a little bit about torture.
That's amazing. And, you know, I'm sure you'll be happy to know I recently onboarded somebody to work in our department. And as I was telling them about our department, they said, EthnoMed, this is where it's from. Oh, my goodness, I read it all the time. And then another staff member went to Somalia and they saw a physician in Somalia, and they saw the Somalian physician looking at the website.
Most of our hits are from NGO. I mean, like when you look at where we get hit from Phnom Penh, we get hit from Addis mostly, and it's NGOs, I think, and people there, because the same issues come up, right? If you're looking at colonizing forces, technology is a colonizing force. And so docs that are inculcated into Western medicine in Addis, in some ways, they think like me than they do the village people, right? Because now they've been colonized internally by medicine. And so for them to kind of be reminded, this is how you talk to your grandmother across this barrier. This is what needs to be explained. It's a great reminder. And then clearly all of the NGO employees that are from other countries that are living and working in Addis or Phnom Penh.
Mm-hmm. Thank you. Well, I'm just so happy to know that it's being used and used widely. As we see, it has a global footprint. So that's wonderful.
I think the exciting thing now is that the person who's in charge of the student program now is an Afghan asylum seeker that we got asylum for at Harborview and then hired. And he's brilliant, right? Hassan Shagan, who you know, is now part of the department. But that's the whole throughput. He sought asylum. We got him asylum. You know, we got him asylum. We got his ear fixed. You know, and then we got him a job, and he's just doing brilliant work.
That's really amazing, and I'm so glad that I get to work with him. And yeah, thank you. Well, another question that we ask on Interpreting for Healthcare podcast is we ask you to talk about your current biggest challenge. And I don't know how relevant this question is now, if you're still interested in being involved in language access or talking about culture and how that affects power imbalances. But yeah. So it's a very open question, basically.
Yeah, the biggest innovation, of course, in the last 15, 20 years for us has been the electronic medical record, right? And how that's changed clinical practice. And so once upon a time, we had a thing called Mindscape at Harborview, which was predates Epic. And the EthnoMed logo was on the banner of, so you could be in the medical record charting on your patients. And if they were, and their language was identified, let's say it was identified as Cambodian, then it would point you, you could click on material that was relevant to Cambodians on EthnoMed. That kind of thing can be done on Epic. It hasn't been done yet, so that you can go, having identified the language spoken or languages spoken, right? Somebody speaks Mandarin and they speak Chao Zhou and they speak Vietnamese. You could go to whatever materials they read best and find materials for them through identified icons within the medical record. That would be great. We had that before, they need to do that again. But I think the biggest challenges have to do with, now that we sort of assume interpreters should be available, the cost and the deployment of interpreters to the scads of places that they're needed. You know, so for example, you're screening somebody for COVID, or you're giving somebody an immunization for COVID. Now, if you've got a Somali interpreter there to do that, they're not in oncology where they're needed, right? Or they're not in the unit where they're needed. And so you've got limited resources, and how do you deploy them? And you need to start looking at, and we were doing this before I finally gave up and got out. But we were doing this where we were sort of thinking, what are those practices where a QR code, right? Will you just click on the QR code, it's on your AVS, it takes you to a little YouTube vignette that says, this is what's going to happen now. And the person goes home with their, let's see, fit test, or they go home with their, I don't know, some routine test that they're going to do at home, stool test for O&P or something. And they have their QR code, they've got their smartphone, it takes them to a little YouTube vignette in Oromo, in Portuguese, in whatever language, and they can watch the instructions that they need again and again and again and again. And you don't need to take an interpreter offline to do that. And there are just dozens of those things. In radiology, it's how we need you to behave in the CT scanner, right? You don't need to pull an interpreter in there for that. You can use a QR code where you've got a really well-trained, interpreter. And so we had, Gamada and Anab and people recording these little sessions for routinized things like this. That then frees up interpreters to be used in more meaningful ways, right? Where you really need them. And I think that there will be challenges that come up around AI, Google Translate, these things where you realize, okay, this is not the solution you think it is, but it will serve some purposes in some situations. Just like a telephonic interpreter is not ideal for a new encounter or for a family conference or for an end of life discussion or with a schizophrenic, but it's really useful for some just routine on checking on your blood pressure control. It looks pretty good. I can use a telephonic interpreter for that, those routine things. So it's understanding, and AI may have some, I don't know what it would be, but there may be some Google Translate AI kinds of utilities like the QR code thing that are suitable for certain situations. And those need to be studied and understood because it frees up other really vital resources for that long end of life discussion in the unit with that. It's going to go on for an hour, right? You don't want that person interrupted. So then you're in a position where not only do you have specialization in oncology and surgery, et cetera, but now you've got different modalities that you can deploy to the right. And we can become very sophisticated in our use of this. Also through the electronic medical record where things get scheduled and identified. This person speaks both Vietnamese and Mandarin. So, we don't have Mandarin available. Let's send a Vietnamese interpreter. They've identified themselves as having spoken both. We can nuance the hell out of people's insurance, believe me. So if we can do that, we can do it for language and both written and spoken ability. So those are the things that I think I would get excited about where I'm still working is sort of how to make sure that we went old school when it was best to go old school in those situations in psychiatry, as I've already said, or wound instructions or end of life. And we went to new technologies when it was simpler, more routinized things that we realized this is just a slam dunk. It's I need it urine, I need it clean, I need it now. How
I love that. I love the idea of utilizing a very wide variety of tools, if we can call interpreters tools, and other auxiliary sort of tools and devices, and then just knowing when to use one, right? Don't use Post-it notes to communicate a diagnosis, but maybe using that to say I'm calling an interpreter, and one will be called, or not necessarily a post note, but but definitely using everything we can to ensure that we close the gaps in language access as we're potentially waiting for an interpreter to arrive.
One of the things that Bob Putch and I used to talk about a lot, because Bob had a real affection, as I did, for the Min community here in town. And so it was the problem with small languages, right? You've got 12 Mun speakers. You've got, I don't know, a half a dozen, that of people in your, in these small communities that come into town. There aren't any identified interpreters, or that language is very limited, or the hospital can't afford to hire an interpreter. So you're going to the phones and there's nobody on the phone. And that problem, I think, of small communities always remains with us. And that's where I think a lot of this, as you're struggling to provide care, these additional tools will fill in some of those gaps, in a way, in that language, in clear ways. And it may be that we could actually do some creative palliative care, wound care kinds of things in small languages on between YouTube and QR codes for AVSs for people that are in small languages. Whenever I used to have a Mongolian patient, and my Mongolian interpreter was in San Francisco, and we were here, and we got to know each other because we just were always working together. And that's a way, I think, to actually work with somebody that's remote, record something that is going to come up again and again, let's say around pain medicines or something that you want the whole family that speaks Mongolian to understand at home.
Yeah, that is an excellent point, because when we talk about, leveling the playing field between people who speak English and between those who speak limited English proficiency, we want to level the playing field for everyone, including speakers of languages of lesser diffusion. So that is an excellent point you're making.
And I think the other thing there is the power difference between doctors and everybody else, right? So if somebody's going to deploy somebody's going to deploy an interpreter, it's the vascular surgeons, so, but what about the PT, or what about the psychiatrist, or what about, and so those ways that we can make sure that the power structure within the hierarchy of medical culture is also leveled, right? So that pharmacy gets their interpreter as well as the vascular surgeon.
Absolutely. Yes. Yay for interpreters as part of the medical team of the healthcare team.
Way past that. So we just, now we need to start to get really smart, I think, and efficient.
Yeah. Well, you spoke to that a little bit when you talked about integrating some information and some kind of QR codes into electronic medical records. But looking forward, what are some other things that you would love to see happen?
So the things that I mentioned are kind of the things that are hottest topics for me. I think that I think scheduling is always a challenge. I mean, I always felt horrible for the schedulers, because medicine is both scheduled and emergent, right? And so, and they're both, right? Somebody comes in routine care and you go, damn, this just became emergent. And so I think that it's really hard for the interpreter schedulers to sort of know how to manage that. And somebody's going to be transitioned from the clinic to the ER, and now they're really needed in the ER, and they're about to go off. They got Chronos, they got to sign out. They're not allowed any over, all of those dynamics, which become very challenging. So I think that how to block interpreters where you need to block them, and how to make sure that you've got, for those appropriate places, the flexibility of interpreters to follow a patient. I think, and then between institutions, right? The CCMs were powerful for that reason. They could go from here to Children's, they could go from Harborview to the U, they could go to the cancer center and follow a patient if they needed to between institutions. But most job descriptions are not written that way. They're written for that institution where the person works, and they don't have any real kind of authority or capacity to work outside of that setting that they're covered. And not to mention their time is allocated to that place. So I think the challenge of scheduling and following the patient according to the natural evolution of an illness, both emergent and scheduled, is something that IT's good at, and the electronic medical record could be better at. And so how to use those skills as we begin to really sort of make use of. And I think interpreter training is the other thing. Finding young people that are willing to do this job is becoming harder and harder and harder. And then there's this whole generational change. When I first started in medicine, doing this at Harborview, many of the people were coming from parts of the world where Western medicine was unknown. In the last 30 years, it's really hard to find a part of the globe where Western medicine is not known and practiced. And so that means also that the young people are highly acculturated to the West and to technical ways of thinking. And that may serve people in their cohort, but it doesn't serve their parents or grandparents. And so finding young people that are really now capable of talking across the digital divide really to older people is a challenge, I think, as well as people willing to do the job, which is a challenge. So how to train those people and explain to them what they don't know, because any of us who have kids realize that those kids, unless it's relevant to them, they don't really care about it. And so that limits them, and they don't really understand how it limits them.
Mm-hmm. So basically, we need to find a way to get them trained, keeping their interest, and without sounding too old, and without going into, hey, at your age, my internet was the newspaper.
Right. To make them see their own, I think once you start to see your own linguistic restrictions, that you're speaking, but nobody's understanding.
Mm-hmm, mm-hmm.
And they really aren't understanding, and that is actually after all your job, then you start to say, okay, I got to have more facile ways of communicating. I can't just rely upon this one trick. I've got to have multiple tricks for making myself understood. And it might involve drawing. It might involve knowing a different lexicon for a different group of people.
No, absolutely. Keeping up with, I think you're kind of touching upon a very important topic, is that finding a way to communicate across generational divides, the digital divide, and then between the ones who are here and the ones who are there, mm-hmm. and how the language that is left over there, whatever there might be, how it continues to evolve. Mm-hmm. And yeah.
I think one of the things that's obvious for that is, I think, geriatrics, right? So that if you've got older Vietnamese people in geriatrics, then you want somebody who really understands that generation and speaks that kind of Vietnamese to be able to do that work. And that creates a niche for somebody. Mm-hmm. And so it does mean that sort of your average 25-year-old that's doing this work speaks Vietnamese kind of as a second language, but doing this work to sort of get by while they're in graduate school or whatever. It may not be the best person to assign to the geriatrics clinic to be working in that, because they don't know what they don't know.
That's very true. All the more important to do more training, where we don't necessarily teach people what things, but like you said, making them realize what they don't know.
Mm-hmm. And I think the interpreter services department has to understand that first, right? So you guys got to get together and sort of say, these are the huge gaps. This is kind of how we need to deploy our services. We got to be really clear on this, so that then when it's time to do that, you've got a very clear understanding of what it is you're trying to do.
Okay, well, you certainly gave me some food for thought as somebody who works in interpreter services and as an interpreter trainer. So I feel like I'm going to stop recording and just go jot down some ideas. So thank you so much. It has been delightful talking to you. I thank you so much for coming onto the Interpreting for Healthcare podcast, where we talk about ensuring language access for all. And thank you for the part that you have played in ensuring language access for patients here at Harborview, but also in Seattle, and I would argue nationally as well.
Well, it was the joy of my life. I really enjoyed it.
Thank you, Carey. Thank you for all of us who do this work, and for all of us who have benefited from this work, especially your patients and their family members. I know it means the world to them, and they travel far so they can get their care at Harborview.
Well, it's
because of programs like yours.
Right. It was a great deal of fun, and it was right? I didn't do it. It was, the fun of it was people working with Miliana and working with Martine and working with Mame and working with all the people that we recruited, to just the joy of that teamwork. Christine, you can name so many people. That was the fun of it, was doing it together with this really diverse group of people.